With this week's Cardiology Countdown, we have another new study at the number 3 spot looking at the duration of TV viewing and the risk of developing diabetes, MI, and death. And this was a meta-analysis of the world's literature on this, of which they culled out 8 large studies comprising 1.1 million person-years of follow-up, and found that there was about a 15% higher risk of developing diabetes, and interestingly, MI and death, all about that same percent increase per year for every 2 hours of additional television viewing. And thus, the absolute rates would be low overall in a normal population, and they calculated it's about a 1 to 2% absolute risk of these events over a 10-year period, but one that links up something that many people do with a higher risk of these events, and thus further impetus to get moving. At the number 2 spot is an interesting analysis of ambulance diversion and the risk of mortality in patients with acute MI. This would be an obvious issue if the nearest hospital was closed and you had to go further. But data have been lacking about the real outcome data. And so an interesting analysis of about 13,800 Medicare patients in a case control study where they looked in 4 counties in California, linking up zip codes of the patient and the nearest hospital, and looked at how often those hospitals were on diversion. Now, amazingly, the mean time of diversion was 6 to 7 hours a day at many of these hospitals. And so when they looked, they found that people who live near hospitals who did not have their hospital on diversion or up through 12 hours, there was not any apparent difference. But those who were exposed to hospitals with more than 12 hours of diversion a day had a significantly increased early and late mortality, about 3 to 4% absolute increase in mortality early that was sustained out through 1 year. And thus, very hard data to say that the practice of emergency department diversion may really be impacting poor outcomes for acute MI patients and drive some policy changes to try and minimize that. And at the number 1 spot is a very interesting analysis done of ICDs with regard to any risk posed by driving in such patients. This was a study done in 2,786 patients from Leiden in the Netherlands, where they looked at both primary and secondary prevention ICD patients and their risk in general and following inappropriate or appropriate shocks. In the first 2 categories, they did not find any increased risk for private drivers, that on average they calculate drive about 4% of their waking hours. Whereas for patients who had just suffered an appropriate shock, they found a much higher risk of events and potential harm to themselves and others over the next 2 to 4 months, during which time they recommended, on the basis of this, restriction against driving. When looking at professional drivers, and this would be bus drivers, taxi, truck drivers, etc., they found that they spend so much time driving that the risk of harm to themselves and others is too high for any ICD patient, and thus recommended that they should no longer drive professionally. This is not a society recommendation, but I think provides very interesting data that the cardiology societies can use to help guide future recommendations. So with this week's Cardiology Countdown, I'm Chris Cannon.